This morning, Jasmine and I are going to be talking about a review of parenteral nutrition in pediatrics. So some of our objectives are that we're going to define parenteral nutrition, recognize primary goals and indications of PN therapy in pediatrics, explain the characteristics of macro and micro nutrients associated with PN, and then Jasmine's probably going to go over some of the metabolic, infectious, and mechanical complications associated with PN therapy. So we all know what parenteral nutrition is. It's an intravenous delivery of nutrients, including carbohydrate, fat, protein, electrolytes, vitamins, minerals, and water. So the proportion of these nutrients are individualized based on the assessment of the patient's clinical and nutritional needs. So the goals of PN nutrition are obviously to provide adequate calories, nutrition during the time when the patient's not able to take oral or enteral feeds. It's also to preserve and restore the process of protein metabolism. We also want to prevent the development of protein and or calorie malnutrition. Also, weight loss, we want to prevent, maybe maintain or increase weight. Also to promote wound healing. So what are some of the indications of using parenteral nutrition? So obviously, if the patient is not able to take an oral diet and or enteral feeds, the gastrointestinal tract does not function properly, like in malabsorption, or the intestinal tract cannot be accessed if there's like an obstruction. So the time frame of when to start this is kind of, I guess, sort of iffy a little bit, but when you look at infants, you probably want to start thinking about starting PN nutrition if around 3 days, if you are not able to advance to PO or a tube feed. With children and adolescents, it's usually about 5 to 7 days. However, if the patient is malnourished, you definitely want to probably start around 3 days. One of the big things is that if the gut is working, you obviously want to use that. So really the only reason you would use PN nutrition solely is if you're unable to give any type of oral or enteral feeds. You can use PN nutrition in conjunction with an oral diet or a tube feed. So for instance, if the patient is able to take an oral diet, I wouldn't do oral diet in TPN because if they're able to take an actual diet, then I'd put a tube down and actually feed them enterally. So one of the main things you need to know when you get ready to start PN nutrition is what type of line you have. So we can give PN nutrition peripherally or centrally. So if you're looking at peripheral nutrition, you want to think about more short term, less than probably 1 to 2 weeks. Also, if you can't access centrally, you would need to do peripheral. One of the main things about peripheral nutrition is that you really need to be able to give a good bit of fluid, oftentimes 1.5 of the maintenance to try to actually meet their nutrition.
That's Callie.
Yes. Did I say Callie? So with parenteral nutrition, one of the things that you need to watch though is the osmolality, and it has to be under 900 millimosmoles per liter. That's one reason that we maximize the dextrose only at 12.5%, because dextrose is one of the major contributors to osmolality. When you look at central nutrition or PN nutrition, it's more long-term. So you're thinking more over 2 weeks. It isn't fluid restricted. This is probably going to be someone who might go home on PN nutrition, and that you're actually able to meet the nutrient needs. When you look at the types of solutions that are available here in Children's Hospital, use a 2-in-1. So basically that means that your dextrose and amino acids, your electrolytes, your vitamins and trace elements are in one bag, and your lipids are hung separately. Over in the adult hospital is where they use a 3-in-1. So everything's in one bag. So the components of PN nutrition, basically you should be able to provide everything in PN in parental nutrition that you would get in a normal healthy diet. So when we actually look at the nutrients, they are divided into macronutrients, which are your carbohydrate, protein, and fat. Your carbohydrates in the form of dextrose, protein and amino acids, and fat as in lipids. Then you have your micronutrients, which are vitamins and trace elements and minerals. And then of course your fluid electrolytes. So when you get ready to actually look at starting PN nutrition, this is kind of one of the most common ways that we're figuring out fluid needs. One of the things that you need to think about though is when you are looking at fluid needs, are there reasons that you might have increased fluid needs as far as, do they have a fever? Are they having any GI losses like stool or any NG output? And then of course, are we fluid restricted as well? Maybe some cardiac issues. The other thing to think about besides what you're giving in the PN nutrition is also, are there other drips going on like antibiotics, any kind of drips for medications? So you may have to include all of that as far as if there's some cardiac issues. So when we look at actual calorie needs, I would say this is one of the most challenging parts of figuring out what to give. One of the reasons why is that, as we all know, when we look at getting our anthropometrics, it can be sometimes inaccurate as far as looking at their height or their length. We know that a lot of times, unfortunately, we don't have length boards. So what ends up happening is that they'll lay the child out on the bed, mark the head and the feet, and then spread the actual sheet out. And so it's not real clear exactly how tall they are. And then with the weight, oftentimes in the in the ICU, they'll use that bed. And if I'm not mistaken, I believe under 10 kgs, those bed weights are not very accurate. So sometimes that is really hard to figure out exactly what are their energy needs. So this is kind of a guideline as far as when you are looking at various ages of kind of looking at calorie needs if you do not have an accurate height or weight. Now, if by chance I know that they have actually gotten a good height and weight on the child, I actually may use the WHO or the Schofield equation without an actual stress factor to it to begin with. With the WHO equation, that's just using a weight in that equation, where the Schofield actually uses height and weight. So one of the main things that you want to look at when you're thinking about calorie needs is looking at what's going on with the patient. We know that energy demands can be decreased because they're in the bed, resting, also sedation meds, or if they're on the vent. So if you're looking at, you may start at the low end and then change it as the patient's clinical or nutritional status changes. One thing to know is that if a patient comes in, and let's just say, for instance, they are on tube feeds at home, you could do the calculations of what those tube feeds are and then give 10 to 15% fewer calories to start with as well. So when we look at the micronutrients, so obviously this right here is kind of on the back of the TPN sheet. So this is kind of where you could start as far as looking at the protein, the dextrose, and the fat. So when we look at the fat, obviously, your protein. Your protein is there. It's not really an energy source. Basically, what protein is doing is it's trying to support the lean body mass and the production of proteins that are essential for metabolism. As far as protein goes, 1 gram equals 4 calories. So when you are looking at the protein, you may start at 1 or 1.5 grams. Usually you don't want to go above 4 grams per kg per day when you look at protein. So when you are looking at protein, you can see that based on age, there's different ranges. So one thing to realize is that, you don't have to stay at one set number, is to kind of, again, look at what's going on with the patient. Do they have some trauma? Are they having some wounds? You know, what are some things that could go on that could actually cause us to have to give more protein? One thing I will tell you is that if you are fluid restricted, if you're trying to decide between giving calories or protein, always make sure you're giving the protein that they need. You do not want to go below what the DRI is as far as protein goes. So when we think of dextrose, dextrose is one of the major sources of non-protein calories. When it comes to the dextrose or carbohydrate, we're trying to aim between probably 40 and 55% of the calories. When you are looking at your dextrose, 1 gram equals 3.4 calories. One of the main things you want to do is to kind of do a stepwise. So you don't want to start out with what their actual goal is. You want to slowly go up on that. One of the main things that we look at, and I know I've preached to all of you, is the glucose infusion rate. And basically what that's doing is it's looking at how quickly carbohydrates are delivered to the patient. If your glucose infusion rate is excessive, you are at risk of having hyperglycemia, high triglycerides, fatty liver. Also too, if they have some pulmonary disease or pulmonary issues, it could also cause some excessive CO2 production. When we are looking at glucose infusion rate, obviously it varies based on the patient's age. As you can see, some of the goals are for infants, it's 10 to 14 milligrams per kg per minute. 1 to 10 is 8 to 10 milligrams per kg per minute, and then 4 to 6 for over the age of 10. I know it's sometimes that we kind of go over that, but one of the things is that we do actually try to watch the glucose infusion rate. How do you calculate that? You can see the equation down there. Now, one thing to realize is that 1.44 is reflective of a 24-hour. So if the PN nutrition is less than 24 hours, basically you take the hours, multiply it times 60 and divide by 1,000. But that is one way you can calculate it out. So when we look at fats again are going to be a good energy source. So 1 gram equals 10 calories. And that's because of that glycerol in it. Causes it to go up to 10 calories versus 9. One of the things that the fats are doing is trying to prevent essential fatty acid deficiency. So to prevent that, you need about 2 to 4% of your calories coming from your essential fats. One of the things that you can do is, let's say, for instance, based on labs, or if they are having to watch how much fat they get, you can look at a serum trying to tetraene ratio. Oftentimes that's really not done that much, but it is a lab that you can do to assess for essential fatty acid. What you'll see with essential fatty acid is that you'll see it as a biochemical diagnosis before you actually see some of the clinical signs as far as the dry, scaly rash, the hair loss, or the impaired growth. So if your trying to tetraene ratio is over 2, that is signaling that there is an essential fatty acid deficiency. Usually when it's above 0.4 is when you'll actually see the clinical signs. So how do we prevent that if we are having to watch the amount of fat that we're giving or lipids? One thing to do is to actually give like 0.5 to 1 gram per kg per day. And you want that to be the intralipids. One reason is that your intralipids are going to be higher in your essential fatty acids than SMOF, or obviously the omega-VIN. The other thing I wanted to tell you is when we do look at the fat or the lipids, we do have a range of 1 to 3 grams. And again, that 1 to 3 is a range. It doesn't mean that you actually start with 1 and get up to a goal of 3. So it really is, again, depending on what's going on with the patient. So I just wanted to kind of let you know that there are 3 different types of lipids out there. There's intralipid, omega-VIN, and SMOF. SMOF lipids basically are a combination of a soybean oil, MCT, which is a coconut oil, olive oil, and fish oil. So one thing you do want to be careful though is if your patient has a soybean or a fish or an egg allergy, you would need to be careful as far as what type of lipid you would use. Now, Intralipid is 100% soybean. If they do have an egg allergy, you do need to be cautious with that. And you probably have to do a test dose because there is that egg phospholipid, which is an emulsifier in it. So when we are looking at lipids, one of the things that we definitely want to do is to make sure that we are clearing those IV fats. So as far as trying to figure out if we are clearing them, we want to get a baseline triglyceride level. Ideally, it'd be nice if you could get it fasting, but if you can, at least get a baseline. And then as you are changing the amount of lipids that you are giving, you do want to try to get another triglyceride level. One of the things that's important is that you want to make sure that your lipids have at least been stopped for 4 hours prior to drawing a triglyceride level. Sometimes we forget and we'll actually draw it during the infusion of lipids and we come back with these high triglycerides. So just make sure either you get it before you try to start the lipids or 4 hours after it's stopped. So Jasmine's going to go ahead and talk about the electrolytes.
Okay, so here's just a brief chart going over your daily electrolyte requirements, and it's divvied up between preterm, infants, and adolescents. So really, when you're looking at your electrolytes, we just recommend that you approach it utilizing these recommended ranges. One thing we do want to point out, though, is for FOS, you do need to be mindful that on the sheet, when you're filling it out, it isn't MEQs per liter, but when you're looking at your dosing recommendations, it does come off as millimoles per kg. So keeping those units in mind is the big thing with that. So calcium and phos, there are limitations to the amount of calcium and phos that we can place into a parenteral nutrition. And that is because calcium and phos can precipitate depending on the amount that's added. The system that we use, Abacus, when we put in the pharmacy orders for this, will actually calculate the ratio for us and let us know if there's an appropriate amount that is in there. So we will reach out to you guys if there's concern regarding that. One thing I think you see mostly in the NICU is knowing that cysteine is a component within the amino acids used primarily in the NICU that actually helps lower the pH. And so that actually allows us to add a little bit more calcium and a little bit more phos to those TPNs that we order in the NICU. And then there are some factors that affect calcium and phosphorus. So temperature, the concentration, so that ratio of calcium to phos, the type of amino acids. So as I was mentioning with the neonates, their type of amino acid that we use will actually lower the concentration or the pH to allow us to increase the concentration, the dextrose concentration, and then the pH of the final solution, and then the order in which we mix that, which you guys don't really have to deal with, but as far as our compounder downstairs and making it, they will place it in a particular order so that we can maximize the amount of calcium and phos. Multivitamins that we do have or we place in the parenteral nutrition. So just keeping in mind your fat solubles, your ADEC vitamins that we place in there, as well as your water soluble, which includes your vitamin C and your B complex. The multivitamins that we do place in the TPN do not contain an iron supplementation, so keep that in mind. And then for patients who become renally impaired or renally impaired at baseline, we typically will reduce the dose by 50% for these patients. Next, I'll go over your trace elements, which include your zinc, copper, chromium, manganese, and selenium. So for zinc, it is utilized to promote wound healing and promote immune function. Patients at risk for deficiency of zinc include patients with diarrhea or patients that are experiencing abnormal fluid loss. And our neonates and infants tend to have a lower amount of zinc. As I mentioned, this is clear. Many of these are renally cleared, so zinc is one of them. Next is chromium, which is a cofactor for insulin. And this deficiency can lead to a glucose intolerance, and this one as well is renally cleared. For ones that are renally cleared, again, you would approach it by reducing by 50% with patients who are renally impaired. Or another approach, if you think of it as an HD kind of schedule, you can put it in there 3 times weekly, similar to if someone was on an HD dialysis schedule. Next is manganese. Deficiency is not very common in humans, but the concern is actually on the opposite side of where if it's accumulated for long periods of time, it can actually lead to neurotoxicity. So a lot of times we will monitor for those types of side effects, especially in patients who are having some type of liver impairment primarily is where you're concerned about your manganese. Next, you have your copper. So deficiency in copper can lead to anemia, leukopenia, and neutropenia. Risk factors include malabsorption, severe malnutrition, and diarrhea. Copper is also another trace element we are concerned with accumulation that can occur within liver disease. And then selenium is our last one. Deficiency in this can develop within 6 weeks. Deficiency can result in cardiomyopathy and decreased growth. The toxicity of it is rare, but typically we will remove it from the TPN if there is a patient that is renally impaired. Some common additives that you'll see that you can order on the sheet includes iron dextran. It is the only compatible iron formulation that we can put directly into the TPN, but you do have to test dose this due to the high risk of anaphylaxis associated with it. And then also because it's an iron supplementation, you do have to monitor for iron overload. There is another option. So if a patient can't, for some reason, get iron dextran in their TPN for whatever reason, we can do a peripheral administration of our iron sucrose formulation. So some patients will actually come in and get an iron sucrose infusion who are on home TPNs without having it added to their TPN orders. So that's one way that we can also alternatively do that if we cannot put iron dextran. Next, we have levocarnitine. So levocarnitine is responsible for transporting long chain fatty acids for energy production. And the dose for that is usually around 10 mg per kg. Other additives that you can add to the TPN include your H2 antagonist. So famotidine is the only option. We used to have ranitidine, but of course that's no longer on the market. Protonix is not compatible, so you only can do this one H2 antagonist. There is an option to do regular insulin in a TPN, but we will never, or Kelly can speak to this if we've ever done this, but I have been told that we typically will not do insulin in TPNs just because of the risk. And then we will add heparin sometimes to prevent thrombophlebitis if there is concern with that. And then additional things that can be added include albumin as well as vitamin K. Briefly, I would like to just go over some complications that will come along with your parenteral nutrition that you should keep in mind. And those are broken down into 3 types, which include metabolic, infectious, and mechanical. So from a metabolic standpoint, Kelly hit on this a little bit earlier, but hyperglycemia is one of your biggest concerns, and it is going to be your most common complication because of the excess carbohydrates, again, risk of hyperglycemia, fatty liver, and the increased CO2 production. Again, keeping in mind your GIR, we will reach out to you as well from a pharmacy standpoint. When we're entering our orders into our Abacus system, we will monitor that as well for you on the backside, just to make sure the numbers come out pretty decent for the patient. Hypoglycemia is another concern. So abrupt discontinuation of parenteral nutrition has actually been associated with increased risk of rebound hypoglycemia due to just cessation of large doses of dextrose. So what we typically do to reduce that risk is to taper off the infusion every 1 to 2 hours until it's discontinued. Mechanical complications are usually catheter related issues. So some type of occlusion formation, a thrombus, or even displacement can occur. So just being mindful of those risks associated with that. And then this is just really a repeat slide, kind of, again, working through your general approach for starting a TPN order from scratch. And if Kelly wants to speak on that again, but again, we're just kind of looking at recommended dosing ranges or recommended weight-based ranges, starting out with your protein, dextrose, and fats. And just because goals are listed here doesn't mean you have to actually meet those goals right out the gate. It is patient specific. So just tailoring to the needs of your patient, but it's just really a template to kind of help guide you in your initial approach for starting a new TPN order. Here's just a quick summary of monitoring that we recommend for your patients on TPN. So baseline, everyone, we really want to just get the full workup, electrolytes, glucose, all the things, triglycerides. I do have prealbumin on here. I know it's not something we commonly order, but it is something you can consider ordering if needed. And then with every TPN change, you want to make sure you're getting your baseline or repeating your electrolytes, your glucoses, making sure you're checking the MAG and FOS. And then your triglycerides, you want to continue to monitor those, especially as you're continuing to increase your lipids. And then if this is a long-term TPN patient, once they are stable, you at least want to at least get weekly checks on all of their most common labs that you'll need for monitoring and adjusting. And then monthly, or just as indicated, if there is a patient who is receiving iron dextran, or if they're on a modified trace element kind of schedule, so that 50% reduction and they're having renal impairment or liver issues, you want to at least check those monthly. A lot of the trace element labs, though, are send out, so just keep that in mind. And one last thing, I know we'll get a couple of these kiddos that come in that are on home TPN already. So if they come in with the bag already hanging and it's running, just let it run. And then if it's not running and for some reason they bring in the bag with them, we cannot use that because it is not our in-house product. One thing we'll do from a pharmacy standpoint, and even you guys help out with that sometimes, is you getting the recipe from Quorum or Intramed, wherever they see outpatient as far as their TPN orders. And what we will do is just transfer over to our pH formulary TPN form. And we just keep in mind, again, those units, as I mentioned. Our sheet will have the milli equivalents, but Quorum and Intramed actually have millimoles on there. So again, keeping in mind the difference in units and how we order things on our TPN order form. And then determining what type of line access we have. Is it central versus peripheral? If it is a peripheral line, we'll have to remove the calcium, keeping in mind our dextrose percentage as well, and then our osmolarity are other things we'll have to consider depending on the route or the access that we have for these patients. And with that, we will open the floor for questions if you guys have any.
So one thing I did want to tell y'all is, we've been kind of talking about the actual TPN sheet that we have now, but, we're going to Epic. And so TPNs will actually now be electronic. I'm not exactly sure how that's going to look, but I believe that when it comes to your electrolytes, instead of it being per liter, it's going to be per kg per day. So once that happens, obviously we'll get training on how to fill out that form. But just to let you know that there are going to be some changes as far as how that form is going to look. So if no one has any questions, I guess we can wrap it up and y'all can have a little bit of free time.